Antepartum hemorrhage is bleeding from the genital tract. Antepartum hemorrhage is bleeding from or in the genital tract that occurs from 24 weeks gestation to prior to birth. It can be life-threatening to woman and baby and is often caused by placenta previa or placental abruption. Placenta previa. So you can see in this image on the left, this is a normal attachment area, so normal placenta over here. Bubba's there, nice little lifeline. We've got a marginal placenta previa, so it means it's on the margin of the cervix. So you can see the placenta here, and there's baby, and then the complete placenta previa. You can also have a partial, which is somewhere in between here. So the complete placenta previa, you can see here, placenta is completely over the opening of the os, so where the cervix is. During labour, which you guys have already learnt, this needs to dilate. So if this starts opening up, it starts going this way, what's going to happen to the placenta? It's going to rip away from that beautiful vascular bed. Where that is, it's like ripping off a big scab, bleed, 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 bleed. And it also means that this beautiful little baby, this lifeline, is no longer receiving the nutrients. So here, this is your placental abruption. So as I was saying, the placenta comes away from the wall of the uterus. So we've come away. What happens? We start to bleed, and it comes through. And so then we're having this antepartum hemorrhage. And as you can see, it sort of doesn't matter if Bub's in there or not. So as the placentas come away, bleed, 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 bleed. Not good for anyone. So APH complicates 3 to 5% of all pregnancies. It's associated with fetal hypoxia, maternal shock, and preterm birth. So fetal hypoxia, because that baby's no longer receiving that rich blood flow through the umbilical cord. Maternal shock, mainly your hemorrhagic shock, and obviously preterm birth. When it comes to management of APH, we want to do some blood tests to measure how much blood is being lost and to decide if we're going to give a blood transfusion or not. We're going to look at ultrasound testing and monitoring to check the well-being of the baby and what's happening internally. We're going to look at we're going to possibly pop on a CTG, which is continuous monitoring of the baby's heart rate, as well as any uterine activity such as contractions, which is in this image here. So that's our CTG machine, and then you pop the sensors onto mama's belly, and we're looking at if there's anything happening with the uterus, and then if there's any changes in heart rate as well. If birth is imminent, then the baby is less than 34 weeks, so it's not fully cooked. Then we give some steroids, and this helps to aid in fetal lung development. And of course, if mum's bleeding out, so mum's hemorrhaging everywhere, the baby's no longer being provided with oxygen-rich blood, then it's time for the baby to come out and quickly. So often Bub is born through an emergency caesarean birth. Postpartum hemorrhage is a bleed of 500 mils or more following labour and birth, and it remains a leading cause of maternal mortality and morbidity globally. The total circulating blood volume is can be calculated with 70 mils per kilo. Plus then our natural changes in pregnancy gives us an extra 2 litres. So a 60 kilo woman has about 6.2 litres of blood in her body, pregnant woman. If she bleeds postpartum, and she loses 1 litre, then she's lost almost 20% of her total circulating blood volume. So this isn't good. There's 2 different types. We've got primary, which means it occurs within the first 24 hours, and you've then got your secondary, which occurs 24 hours up to 6 weeks after the baby's been born. So you can see here, we've got our uterus, we've got blood, you've got your placenta. When we're looking at causes of postpartum hemorrhage, we're looking at the 4 T's. So trauma, so if there's any trauma to the uterus can actually rupture. So say this woman's had a cesarean here, and then during birth, and then after birth, when we're looking at the causes of postpartum hemorrhage, we're referring to the 4 T's. So the first T is trauma. So one of the things that can happen is the uterus can actually rupture. So this uterus here can actually open. This can occur primarily if a woman has had a cesarean, so there's scar tissue there, and it just opens. It just rips open again. Also, any tears to any of the genital tract. So your vagina, perineum, so down here as well, this can completely tear through, as well as any tears to your cervix. So your cervix is very vascular, has lots of blood in it. So if this rips, then the woman can bleed quite a significant amount. The next T is tone. So basically, to stop the bleeding of a uterus, we need it to clamp down on itself. So just like you would apply pressure to a wound if someone's been stabbed, you're applying pressure, you're pushing on that, so it encourages that scab, those clots to form to block over those blood vessels. So if I always think of it like you're kinking the hose, so you're kinking those blood vessels. So if the uterus is open and floppy, so it doesn't have a lot of tone, then the hose can't get kinked and the woman continues to bleed. So some common causes of this can be oxytocin withdrawal. If your uterus has been stretched lots of times, so if you've had lots of babies, then it takes a lot longer for it to go back. And also if it's tired, so if you've had a prolonged labour. The next T is for tissue. So if there's any retained products, the uterus can't collapse down on itself. It can't fold, it can't clamp over, can't kink those hoses. So if there's stuff stuck in there, so your placenta, membranes, it's not going to kink over, it's not going to stop bleeding. The hose is still going to keep flowing. And then finally, thrombin. So that just basically means that if the woman has a pre-existing clotting disorder, that stops her from actually forming the scab within the uterus to stop the bleeding after having a bubble. When we're looking at management, there's mechanical management. So we do uterine massage, where you can do it externally. So this increases uterine tone, but you can also do internal uterine massage or bimanual compression, which is also what it's called. So midwife will put her fist up in, and you can see how she's using her other hand to actually pull down on that uterus and actually clamp it over, so kinking that garden hose. Often, if you can, depending on space, you can use 2 people to perform this as well. We can also give drugs to either help it clamp over or to stop the blood from coming through. So oxytocin, ergometrin we use to help encourage that uterus to clamp over. We suture up any rips and tears. We remove any retained products from the uterus so that it can clamp back down. This often requires a surgical intervention. However, it can be performed in the birth suite, and I've seen it more than once, where the medical officer will actually reach up in and pull out any retained products, obviously creating issues around infection control. Then we can also top up the woman. So if she's had a significant bleed, then we'll give some red blood cells to increase her red blood cell count within her circulating blood volume. And if there's any other issues regarding clotting, then we give clotting factors as well. Just some references that I've used throughout. Thank you guys. I hope I've increased your knowledge around bleeding during pregnancy and also after birth.